Common treatments for myasthenia gravis include anticholinesterase medications, glucocorticoids and other immunosuppressive agents, thymectomy, plasmapheresis, IVIG, rituximab, and the recently approved complement inhibitors and neonatal Fc receptor antagonists. Anticholinesterase medication produces at least partial improvement in most patients. Pyridostigmine is most widely used and is initiated at 30 to 60 milligrams 3 to 4 times daily. Its beneficial action begins within 15 to 30 minutes and lasts for 3 to 4 hours. The dose should be tailored to individual requirements. For example, taking it before meals helps those with chewing and swallowing weakness. The maximum useful dose rarely exceeds 360 to 480 milligrams daily. Overdosage may cause increased weakness. Muscarinic side effects like diarrhea, abdominal cramps, excess salivation, and nausea may limit the tolerated dose. Atropine, diphenoxylate, or loperamide can treat gastrointestinal symptoms. Importantly, anti-MuSK patients generally obtain less benefit from these agents and may actually worsen. Thymectomy as a treatment must be distinguished from the surgical removal of a thymoma, which is necessary due to the possibility of local tumor spread. The MGTX trial demonstrated that extended transsternal thymectomy in non-thymatomatous acetylcholine receptor antibody-positive generalized myasthenia improved strength and function, reduced prednisone in second-line agent requirements, and lowered hospitalization rates. Patients with ocular, MuSK-positive, and seronegative myasthenia were excluded from the MGTX study, and evidence suggests they may not benefit. Thymectomy should never be an emergency procedure, and less invasive techniques are now used at many institutions, though it's unknown if they provide identical benefit. Preoperative treatment with IVIG or plasmapheresis may be used to maximize strength. Glucocorticoids produce improvement in the great majority of patients. Prednisone should be given in a single morning dose. For ocular or mild weakness, initial doses are 15 to 25 milligrams per day, increased by 5 milligrams per day at 7 to 14-day intervals until marked improvement or a dose of 50 to 60 milligrams daily is reached. The full effect takes 2 to 3 weeks to observe. In severe cases, starting at a high dose is reasonable, typically after IVIG or plasma exchange to protect against steroid-associated worsening. After a month on symptom-controlling dose, it is slowly tapered, no faster than 10 milligrams a month until 20 milligrams daily, and more slowly thereafter. Common errors include insufficient dose or duration, tapering too early or rapidly, and lack of attention to side effects. Mycophenolate dofetil is dosed at 1 to 1.5 grams twice daily. It inhibits purine synthesis by the de novo pathway, selectively inhibiting lymphocyte proliferation because lymphocytes lack the alternative salvage pathway. Clinical improvement may be delayed for many months to a year until pre-existing autoreactive lymphocytes die. Primary side effects are gastrointestinal, with rare risks of leukopenia, malignancy, or progressive multifocal leukoencephalopathy. Azathioprine effectively reduces prednisone requirements, though benefits can take a year or more. About 10 to 15% cannot tolerate it due to flu-like symptoms, bone marrow suppression, or liver abnormalities. Initial dosing is 50 milligrams per day, increased weekly to 150 milligrams daily, or up to 2 to 3 milligrams per kilogram. Allopurinol must never be used with azathioprine due to shared degradation pathways leading to severe bone marrow suppression. Calcineurin inhibitors like cyclosporin, dosed at 4 to 5 milligrams per kilogram per day, and tacrolimus, dosed at 0.07 to 0.1 milligrams per kilogram per day, work more rapidly, but have severe side effects, including hypertension and nephrotoxicity. Rituximab, a monoclonal antibody binding CD20 on B lymphocytes, induces prolonged remissions in MuSK antibody-positive myasthenia. It is dosed at 1 gram IV on 2 occasions 2 weeks apart. A Swedish trial showed a single 500 mg IV infusion improved outcomes in new-onset acetylcholine receptor-positive patients. High-dose cyclophosphamide may induce long-lasting benefit in refractory patients by eliminating mature lymphocytes while sparing stem cells. 3 complement inhibitors, eculizumab, ravulizumab, and zilucoplan, are FDA-approved for acetylcholine receptor-positive generalized myasthenia. They inhibit C5 cleavage in the terminal complement cascade. Eculizumab is dosed with a loading phase of 900 mg IV weekly for 4 weeks, then a maintenance dose of 1,200 mg IV on week 5 and every 2 weeks thereafter. Ravulizumab uses weight-based dosing. For example, an adult between 60 and less than 100 kilograms receives a 2,700 mg IV loading dose, followed by 3,300 mg IV every 8 weeks for maintenance. Zilucoplan is self-administered subcutaneously with weight-based daily doses, 16.6 mg daily for under 56 kilograms, 23 mg for 56 to under 77 kilograms, and 32.4 mg for 77 kilograms and above. These medications increase the risk of meningococcal infection, requiring vaccination at least 14 days prior to treatment, or prophylactic penicillin if started sooner. FcRn, or neonatal Fc receptor antagonists, prevent endothelial cells from salvaging IgG and albumin, leading to increased catabolism of IgG and rapid reduction of autoantibodies. Efgartigimod can be administered intravenously or subcutaneously. The weight-based IV dose is 10 mg per kilogram up to 1,200 mg, given weekly for 4 weeks to complete 1 cycle. The fixed-dose subcutaneous version is 1,008 mg weekly for 4 weeks to complete 1 cycle. Rozanolixizumab is approved for both anti-AChR and anti-MuSK disease and is given as a weekly subcutaneous infusion for 6 weeks per cycle. Its clinical dosing is weight-based, 420 mg for under 50 kilograms, 560 mg for 50 to under 100 kilograms, and 840 mg for 100 kilograms or greater. Side effects for this class include increased risk of respiratory and urinary infections, headaches, including aseptic meningitis with rozanolixizumab, and hypoalbuminemia. Myasthenic crisis is a life-threatening exacerbation, usually involving ventilatory failure, most commonly caused by intercurrent infection. It requires intensive care, ventilatory assistance, antibiotics, and plasmapheresis, or IVIG. Plasmapheresis separates plasma containing pathogenic antibodies from blood cells, typically involving 5 or 6 exchanges over 10 to 14 days. IVIG does not require large-bore access and is typically dosed at 2 grams per kilogram over 2 to 5 days. Improvement occurs in about 70% of patients. Many drugs can exacerbate weakness and should be avoided, including aminoglycosides, quinolones, macrolides, non-depolarizing muscle relaxants, local anesthetics, beta blockers, procainamide, penicillamine, botulinum toxin, quinine derivatives, magnesium, and checkpoint inhibitors. The prognosis of myasthenia gravis has improved strikingly as a result of advances in treatment. Nearly all myasthenic patients can be returned to full productive lives with proper therapy. Mortality from this disease diminished greatly during the 20th century, changing from a mortality of nearly 70% a century ago to 2 to 30% by the 1950s, with contemporary estimates in the 1 to 5% range. The incidence varies in different populations, occurring in approximately 2 to 10 per million individuals in the United States and the Netherlands, and up to 20 per million in Spain. Estimates of global prevalence range widely, from 2 to 360 per million. Age of onset can be influenced by geography and ethnicity. For example, juvenile onset myasthenia is uncommon in Western populations, but may represent more than half of cases in Asians. Musk myasthenia appears to be more common in the Mediterranean area of Europe than in Northern Europe, and is also more common in northern regions of East Asia than in southern regions. And that's our comprehensive dive into the treatment and prognosis of myasthenia gravis. If you found this video valuable, please take a moment to hit the like button and subscribe for more high-yield content. Thanks for being part of our community, and we'll see you in the next video.